ओम धम धन्वंतरे नमः। कर्पूरगौरम करुणावतारम संसारसारम भुजगेन्द्रहारम सदा वसंतम हृदयारविंदे भवम भवानी सहितम नमामि. Let me share. This topic is ascitic fluid tapping. Ascites means collection of fluids in the peritoneal cavity. When the peritoneal cavity fluid present in the peritoneal cavity exceeds 1500 ml, is mild ascites. 1500 ml to 2000 ml is moderate ascites, and more than 2000 ml it is considered as gross ascites, severe ascites. So causes of ascites are many, like cirrhosis of the liver, nephrotic syndrome, congestive cardiac failure, and tubercular ascites, and chylous ascites, and malignant ascites. Normal abdomen and ascites. Parasynthesis is a procedure performed to obtain a small sample drained ascitic fluid for both diagnostic and therapeutic purposes. This activity describes the indications, contraindications, complications of parasynthesis and highlights the role of interpersonal talk in the management of patients with ascites. Parasynthesis is a procedure performed to obtain a small sample to drain ascitic fluid for both diagnostic and therapeutic purposes. Fluid may be used to determine the etiology of ascites and evaluate for cancer or infection. Needle or catheter is inserted into the peritoneal cavity and the ascitic fluid is removed for diagnostic or therapeutic purposes. The indications of parasynthesis are: parasynthesis should be performed to rule out spontaneous bacterial peritonitis in patients with known ascites presenting with concerning symptoms such as abdominal pain, fever, gastrointestinal bleed, worsening encephalopathy, new or worsening renal or liver failure, hypotension, or other symptoms of infection or sepsis. To identify the etiology of new onset ascites, alleviate abdominal discomfort or respiratory distress in hemodynamically stable patients with dense ascites or ascites that are refractory to diuretics. A large volume or therapeutic parasynthesis. Parasynthesis should, parasynthesis should be avoided in patients with DIC, the first setting platelets or PFP, or an acute abdomen. Okay. Should be performed with caution in pregnant patients, patients with organomegaly, ileus, bowel obstruction, or a distended bladder. It should be avoided avoid passing the needle or catheter through a sites of skin infection, surgical scar, visibly engorged abdominal wall vessels, or abdominal wall hematomas. So these are necessary. Sterile gloves, sterile drip, travels, betadine, lidocaine, a needle in to inject anesthetic, 25 gauge for the skin, and a highly smaller gauge, slightly smaller gauge needle for the soft tissue. 14 or 16 gauge needle or IV catheter for fluid aspiration. 20 to 60 cc syringe to collect sample of fluid. IV tubing, vacuum bottles or plastic containers. 4 into 4 gauze or bandage. Metallurgy, chemistry, and microbiology sample tubes and blood culture bottles. These are necessary. So the patient with abdominal pain and suppose sepsis is that it will lead to ascites. So, because of the ascites, ascites is caused due to bacterial ascites, tubercular ascites, ascites with cirrhosis of the liver, or nephrotic syndrome, or congestive cardiac failure, or due to hyperproteinemia. Other causes are tubercular ascites, chylous ascites, and malignant ascites. This is a side patient. You can see the destination of abdomen and the extremities are becoming thin. And there may be gynecomastia, case of cirrhosis of the liver. The other patient with ascites, you can see the abdominal girth has increased. There is distension of abdomen due to fluid correction. The fluid correction is up to 1,500 ml. It is mild. It is 1,500 to 2,000 ml. It is moderate ascites. More than 2,000 ml is severe ascites. Another patient where you can see distension of the abdomen. So the initially puddle sign is done. Later the fluid thinnness, fluid dullness, and fluid thin and shifting dullness are observed. Examination. You can see there is umbilicus is included because of ascites. Another patient where you can see ascites, fluid is accumulated in the peritoneal cavity and it is drained. It is removed and collected in a plastic container. So ascitic fluid, if it will be straw color usually, and it will be light pale color. If it is blood stain, it may be traumatic tap or tubercular ascites or maybe malignant ascites. So you have to when you send to the ascitic fluid to the laboratory for analysis, it may be transudate or it may be exudate. So transudate where non-inflammatory surface like excretion of the occur. Exudate from the blood vessel, the fluid takes into the peritoneal cavity where with inflammatory. So the protein, the fluid lactic dehydrogenase will be high, and fluid protein, total protein will be high, more than 3 grams percentage. These are the complementary signs for to detect to confirm exudate. There will be inflammatory cells also exudate. In conditions like tubercular ascites, infectious ascites, and malignant ascites, fluid will be exudate. In case of ascites due to cirrhosis of the liver, nephrotic syndrome, cardiac failure, or hypertonemia, the fluid usually will be transudate. The patient with ascites can see the distension of abdomen. This is the ascitic fluid cytometry. So, fluid for cytometry is collected and sent to the laboratory to see the inflammatory cells, malignant cells, RBCs, etc. You can see the patient with ascites, the abdomen, the umbilicus has depressed. So smiling umbilicus or protruded umbilicus, they are depending upon the severity of ascites. Another patient where we can see distension of abdomen. We can differentiate ovarian cyst and ascites by observing the abdomen. Another patient with ascites. You can see the protrusion of the umbilicus, and there is the vein prominence in the abdominal wall. Another patient with ascites. You can see the distension of abdomen due to fluid collection. The huge ascites, patient may have breathlessness also. It is the collection of the fluid for sending into analysis in the laboratory. Another patient with ascites. So there is a huge abdominal distension. Complications are respiratory distress, pulmonary edema, pleural effusion, acute renal failure, diarrhea, and electrolyte imbalance. You can see the patient of ascites. Cells. This is the structural model of liver. The cause of ascites. Patient of how the fluid is collected. This is the USC, ultrasonography of the liver. So, atresia on this. You can see malignant cells spread. This is the collection, the sample of the ascitic fluid. The liver cirrhosis can also cause ascites. This is the most common cause. Alcoholic liver disease, where alcoholic cirrhosis leads to portal hypertension and ascites. Cells, fluid. The different symptoms of hepatitis. The model, liver. The pedal edema, bilateral pedal edema is seen in hypertonemia and ascitic patients because the serum total protein will be low. Because of that, there is fluid collection, different parts, especially in the legs, and pedal edema. So, supporting pedal edema. Patient after fluid tap. The patient after fluid tap is made backrest is given, is made sit. This is a patient with a bilateral pedal edema. This is a case of ascites with the bilateral general circle. You can see the edema is pitting on pressure. There are symptoms of hepatitis C. This is a fluid. You can see the red fluid, isn't it? So that is maybe traumatic tap or maybe due to malignancy, malignant ascites. The pedal edema stain in the leg. Pitting pedal edema, visual symptom of ascites patients. Today we have discussed the ascites, causes of ascites, and parasympathesis. The medicines given usually hepatoprotective and rasana drugs, diuretics, hepatic stimulants, metinics, and rasana drugs, and so pitta, asakta dravyas, and balya brahmana aushadhi. Thank you for patient hearing.